Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a cataract with yellowish appearance. The patient has proliferative diabetic retinopathy. The patient is suffering from diabetes for the last 20 years. Ultrasonography shows vitreous hemorrhage. So this is the first stage of the management, removal of cataract and intraocular lens implantation. The case will be taken up by our vitreoretinal surgeon after 3 days. As I do the incisions and stain the capsule with trypan blue dye, the pupil becomes smaller. Initially it was dilated to about 4.5 millimeter. Now the pupil has become smaller, and even with adrenaline the pupil doesn't dilate much. Rather, it is small and it is about 3.5 millimeter. And during emulsification of the nucleus it will be much smaller. So I plan to use a pupil expansion device in this case, and the device I use is B-hex pupil expansion device. B for Bhattacharjee, hex for hexagonal. It is a hexagonal pupil expansion device invented by Dr. Suven Bhattacharjee of Kolkata, India. The device is taken completely into the anterior chamber, and with the help of a B-hex forceps, 23 gauge B-hex forceps, the device is used to dilate the pupil. The device is uniplanar. There are flanges and notches. Alternate flanges are tucked under the iris, and the pupil takes this hexagonal shape. And now some more visco and capsulorhexis is to be done. As I make a puncture on the anterior capsule, there is some leakage of some fluid which indicates high intralenticular pressure. So the cataract is intumescent and it appears yellowish, probably because of long-standing vitreous hemorrhage. And now I am using this 23 gauge Simcoe cannula to remove some cortex, and after some time the nucleus rotates and a lot of cortical matter is aspirated. Thus the intralenticular pressure is reduced. In this case the cortex that is trapped behind didn't come anteriorly, so the intralenticular pressure, though reduced, is not satisfactorily reduced, and there is some elevation at 11 o'clock. So there is a chance of rhexis run out at 11 o'clock, and see what happens. Here the rhexis goes to periphery. However, I could retrieve it, and it is a continuous rhexis, though it has gone probably up to the equator at 9 o'clock. And now I am using this pre-chopper to divide the nucleus, but I could not. See, the nucleus is so sticky. It's a gummy cataract, and it doesn't, the fibers are sticks to each other in such a way that they don't want to separate. It's very stubborn cataract. They don't want to separate. And now what to do? Let us see. We have to manage it somehow. So as I try to, now my plan is to make this strange. So I'm planning stop and chop technique. Make this strange go deeper at the central part and not so deep in the periphery. And as I go to sufficient depth, I use the Phaco tip and the chopper to get two halves. Now here I am trying to pull this half out of the capsular bag, but I could not. It just didn't come. And now I am creating a bowl kind of appearance, and suddenly the piece on the right side comes out because the rhexis ran out in this area, so this part of the nucleus came out of the bag. And see, even though it is not a very hard cataract, it's very stubborn. It doesn't want to come to the tip, and it doesn't want to separate. But now it has no other way, it has to separate. I am using a ball tipped chopper in this case. The length of the tip of this chopper is 1.5 millimeter, so it is not a very long chopper, only 1.5 millimeter length. And now we see a reddish appearance in the vitreous, so there are some fresh blood in the vitreous cavity. There is vitreous hemorrhage, and the patient will require vitrectomy for complete management. And now after injecting visco, I remove the cortex. Removal of cortex is not easy in such cases, in such gummy cataracts. So when the cortex is removed, I inject visco, and when there is B-hex, we should enlarge the main wound a bit so that the tip goes beyond the B-hex. The tip of the cartridge goes beyond the B-hex and delivers the nucleus beyond the B-hex, and thus the lens goes in the capsular bag. And now this is, I am checking if there is any cortex somewhere and whether the haptics have gone in the capsular bag or not. And now removal of B-hex ring with these forceps. We have to disengage the flanges, untuck the flanges, and just pull it out. This is a very thin device, it comes out through a very small wound. And now I have completed the case almost. We just have to remove the visco and form the antechamber nicely. I take bimanual irrigation aspiration and remove all the visco from the anterior chamber, from the posterior chamber, and now we are towards the end of the surgery. This is a bit of moxifloxacin. And now the side ports are closed by hydrating corneal stroma. And then a final lavage of the anterior chamber is done with the help of this 23 gauge Simcoe cannula. the antechamber is then very nicely formed and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy and great surgical competence.